Today I will be discussing an article written by Frawley, Smith and Polisar in 1991. It is titled 6 and 12-month abstinent rates in inpatient alcoholics treated with aversion therapy compared with matched inpatients from a treatment registry. It is from the journal Alcoholism, Clinical and Experimental Research, Volume 15, pages 862 to 870. The authors state in their introduction that the efficacy of treatment of alcoholism has been criticised for poor research design. This is due to lack of adequate controls, small size of studies, a lack of attention to appropriate research procedures and other problems. Patients treated at the Schickshadel Hospital had volunteered for this study. They were admitted for 10 days of multimodal treatment program that combined 5 alcoholic aversion sessions and 5 sodium pentothal interviews on alternating days. Daily group counselling and drug-specific information was also provided, and the counselling, including individual and family counselling, was provided. Booster sessions were scheduled at 1 month and 3 month intervals for 2 two-day reinforcement treatments that consist of 1 aversion treatment and 1 interview, a counselling session to review the continued care plan, and participation in group counselling. Patients were also introduced to and prepared for participation in support groups activity following discharge, such as the AA 12-step plan. However, these were not mandatory. Patients that did not take part in aversion therapy were in programs that ranged from 3 to 4 weeks that used the Minnesota model of alcoholism treatment. All utilised the steps of Alcohol Anonymous, AA, and was based on a model of total abstinence. The patient program lasts from 25 to 28 days, during which the patient works on at least the first 4 steps of AA. The patient also takes part in lecture and group sessions, and sometimes programming may extend to 12 hours per day, 7 days a week. The image you can see there shows the distribution of 249 pairs of matching variables, including sex, age, marital status, education, performance problem, missed work, marijuana use, cocaine use, ethnicity, any prior treatment, and last alcohol use. The important baseline variables, including sex, demonstrated that 86% were males, and marital status demonstrated that 79% were married. Other variables, such as age, demonstrated that 27% of the participants were between the ages of 25 and 34, and 81% had missed work due to their alcohol problem. 99% of patients said their last alcohol use was less than 1 week prior to admittance into the program, and 72% of patients stated that they had never had prior treatment for their alcoholism. The authors defined abstinence as the total continuous abstinence during the time interval specified, but more clearly, abstinent means a refrain from the use of alcohol in this situation. The table you can see at the moment demonstrates the results from this study, including for the Schickshadel patients, 85% were abstinent for 6 months, and for the matched patients, only 72% were. Similarly, between 0 to 12 months, 79% of Schickshadel patients were abstinent, and only 67% of the matched patients were abstinent in the same time frame. Table 3 demonstrates both brief, less than 1 time per month, and serious, more than 1 time per month relapses in both the Schick and match groups. It is noted that the percentages increase greatly in the match groups and demonstrate the greater use of aversion therapy for abstinence. Table 6 shows the level of compliance with the Schickshadel recommendations that 2 reinforcement treatments should be undertaken at 1 and 3 month intervals. The data in Table 6 supports 2 points that the authors made. First, the majority of patients complied with the recommendation, and second, there was a dramatic increase in abstinence following treatments. During the first 6 months after treatment, matched patients used more AA, 71%, than Schick patients, 22%. Abstinence rates increased in matched group with increasing AA usage. In this study, the authors found out that for both 6 and 12-month follow-ups, patients from the Schick-Shadel Hospital that used aversion therapy had significantly higher rates of abstinence than those from well-matched patients from other programs that use the Minnesota model, in particular AA. This supports the author's hypothesis that aversion therapy does greatly increase abstinence rates when compared to that of AA groups. Nonetheless, the authors do state that there may be some other factors that account for the differences in outcomes between the Schick program and the Minnesota model programs, such as varying marital status, age, income, education, and other programs they use in the multimodal treatments that have a greater effect that we do not know of. Within this research, other evidence was found that Schick-Shadel patients that used AA had a higher level of abstinence than those that did not. This demonstrates that although AA is not as effective as aversion therapy in treating alcoholism, it does benefit participants and delays the time lapse between treatment and first drink. In conclusion, the authors stated that abstinence rates were improved by aversion therapy and led to the reduction of individual appetite. However, they did also say that the findings should be replicated and used with a greater population in order to generalise these findings. This article, of the 3 that I chose, seemed the most appropriate to talk about as it used a comparison group which the others did not. Limitations included that the patients were from a relatively small part of the population, including they were better off financially and younger in age. Problems included the poor research design, which meant that the method could not be replicated and thus was not validated. Other problems included a lack of adequate control groups and a small size of study. Thank you for watching. I hope you enjoyed.